Okay, so in this presentation, we're going to talk a little bit more about examinations specific to peripheral vestibular system. And in particular, we're going to be spending most of our time on benign paroxysmal positional vertigo or BPPV. But just to clarify, there are multiple different types of peripheral vestibular dysfunctions. BPPV happens to just be one of them. So when we think about peripheral vestibular dysfunction, which we've talked about in the past, peripheral means that there's a damage to the cranial nerve 8, semicircular canals, the utricles, hair cells, anything that is going to be more in the inner ear itself. Okay. We're not talking about cortical vestibular nuclei, way up in the cortical region. This is specifically more in the inner ear area that we're going to be referring to. You can have multiple different types of peripheral vestibular dysfunctions. That can be mechanical, which would be our BPPV. You could have a unilateral vestibular loss, or it's also called hypofunction. You could have a bilateral vestibular hypofunction. There's Meniere's disease, migraine, and cervicogenic dizziness. But like I said, today with this presentation, we're going to focus a little bit more on the BPPV. We'll be hitting the other ones next week, and then doing some things in lab with them next week. Okay, so let's talk about BPPV. Basically, what benign paroxysmal positional vertigo is, it's when the otoconia from the otoliths have broken free and lands in a dependent portion of the semicircular canal, or it attaches to the cupula of the semicircular canal. So basically, those little crystals or rocks that you always hear about and stuff that people talk about, basically they break free from the gelatinous substance that they're in, and they start free floating in the semicircular canals, which is not where they belong. Okay. They can either be free floating, or they can also attach to the cupula and get stuck there. So those are our two options when we think about BPPV. Symptoms of BPPV, your patient's going to come in and they're going to describe that they have vertigo or dizziness related to head changes in their head position. So they are specifically going to give you feedback like, if I look up, I get dizzy. When I roll onto my side and get up in the morning, I get dizzy. So it's when they do the position that their symptoms are going to come on. Now, they may still complain about secondary symptoms such as imbalance, difficulties walking, lightheadedness, a lot of falling that's occurring. These are all going to be secondary symptoms, but typically they're going to talk about some type of spinning sensation, and it's going to be that they feel like the world is moving, not them themselves. They see things moving. Symptoms in general, they're going to last for about seconds to minutes, okay? Especially for the spinning sensation, the vertigo part, okay? Sometimes when that happens, they may have some secondary symptoms because they may have kicked in their autonomic nervous system. So sometimes they may feel nauseous or just off for longer periods of the day, but the actual vertigo spinning sensation will only last usually for seconds to minutes. There's typically a slight lag before the symptoms come on. And as I mentioned, symptoms resolve shortly, typically after the movement stops. Provoking positions that are common that you'll hear of when people have BPPV. They're going to talk about that when they get out of the bed, their symptoms seem to come on. If they are lying down from sitting to supine, they have to sleep with their head raised up. Bending over could bother them, looking up or reaching up overhead, rolling in bed, going from supine to sit. All common times when you'll hear people complain and say that their symptoms are brought on by these positions. So how do we help to validate? Sounds like subjectively that BPPV is probably one of the primary things that we're thinking of, but we also want to double check and make sure there aren't additional things going on, because you can have multiple things besides just BPPV. So we always want to do our oculomotor testing. We're always going to want to assess for any central signs. We want to clear and make sure there's not anything else going on before we go ahead and start dropping somebody's head back and putting them in a position where, we could be cutting off blood supply, different things, et cetera, when we're going in back and into that extension. So we definitely want to make sure that all the central signs are okay. If somebody has a central, like if they've had a concussion already, or we already know they have a neurological problem, we might see central signs. That's a different story. But if this is somebody coming in, they have no history of that whatsoever, we want to check and make sure that there are no central signs before we go ahead and drop them back into a Dix Help hike. So you want to limit your oculomotor testing as well to things that aren't going to turn their head. Because if you're starting to ask them to do all these different VORs, et cetera, they're going to already feel nauseous and sick by the time you go bring them back into your testing positions. You're going to have skewed results. Okay. So one, we're always going to do central testing. Two, we're always going to clear the cervical spine prior to doing any type of BPPV. We want to make sure that they don't have any issues. There's no pain, that we wouldn't have any reason why there'd be cervical instability before we're going to drop somebody back into extension. Okay. So make sure you clear both of those things before you ever perform a Dix-Hallpike on your patient. Okay, so in order to test for BPPV, the standard test that's out there is going to be the Dix-Hallpike. Sometimes you'll hear the Hallpike Dix. They tend to interchange them both, okay? But for our purposes, we're going to call it the Dix-Hallpike. It was developed back in the 1950s, and it's the gold standard. For checking for BPPV, this is what all the research has done. This is going to be the test that we're going to do to test whether or not they have it. Dix-Hallpike looks at the posterior and the anterior semicircular canals to see if the crystals are free-floating in those two canals, okay? We also have the horizontal canal. Remember, Dix-Hallpike is not really going to look at that because based on the way the canals are positioned 90 degrees from each other, those aren't going to really line up to have gravity really affect where the crystals move when we drop them back really quickly like we would in the Dix-Hallpike. So we're going to do a roll test for horizontal canals if we suspect it's going to be in the horizontal canal. However, in general, about 85% of all cases are going to be in the posterior canal. So the Dix-Hallpike is going to be our first choice of method that we would go ahead and look at because the ratio and the odds of it being in the posterior canal are going to be significantly higher. So we would always start with the Dix-Hallpike. If that was negative, but we still thought it was BPPV, then we would move into the roll test. Okay. So as I mentioned, about 85% most common, it's going to be in the posterior canal of the Dix-Hallpike. So we're going to actually teach you how to do the Dix-Hallpike in lab. So don't worry about any of the pictures of that and how do you do the technique. We're going to go over that in lab. But what I want you to understand is that when you drop them back into that position, what we're looking for is a nystagmus. And the nystagmus is going to tell us whether it's in the posterior canal or the anterior canal. Okay? Posterior canal, 85%, most common. Anterior canal is very rare. It's only in about 1 to 2% of the cases, okay? But when you bring them back into the Dix-Hallpike, if it's in the posterior canal, you're going to see an upbeating and torsional nystagmus, okay? I want you to think more about that. It's just torsional, and you're going to see it on a certain side. If you get really into details and you want to do a lot of BPPV testing and become vestibular certified, then we're going to talk more about which way that torsion is going. If we do the anterior canal, we're looking at that it's going to be a downbeating and ipsilateral torsional. So meaning, once again, it's going to beat downwards. It's in the anterior canal, and we're all going to have a rotational component. So whichever ear is down when the nystagmus and symptoms are pronounced is the one that's, hang on one second. So whichever ear is down when the nystagmus is produced is most pronounced, that's going to be the involved side. So if you take them and you drop them back onto the right side, and the symptoms are worse on the right side versus on the left side, then you're going to go ahead and diagnose them with a right-sided problem. Okay. If you drop them back on the left side had greater symptoms than on the right side, then we would think that the problem was going to be on the left side. Okay. So we're looking for upbeating, downbeating nystagmus, and then which ear is down, which one produces the most symptoms. All right, so just so you can see what a nystagmus looks like, hopefully my video is going to come up here in a minute. I don't have very good internet today, but you're going to get a chance to see what a upbeating nystagmus would look like. So this is going to be a posterior canal, BPPV. Let's see if I can get it to play here for you. Doesn't look like it's going to play, and I am actually in a hotel, guys, so I have poor Wi-Fi as I'm going to go over this. So I'm going to ask you to go ahead. You guys should have access to the slides, or I will make sure that I have a video in the lab where you guys can see the nystagmus a little bit more so you can understand what it is. Oh, there we go. Maybe it's going to play now. So you can see there's a latency. Nothing's happened yet.
Team open. Calming down?
Yeah.
Hanging with me. Yeah, it should be settling down.
All right. I don't think this video,
Yeah,
just because
better.
I'm sorry that the lag Wi-Fi, you're not going to really be able to see it. But I'll make sure that I play the video in class for you guys as well so you can see it a little bit better, because it's nice to have the ability to see what the nystagmus is going to look like. Okay? But basically, as we talked about, you have a canalithiasis and you have a cupulothiasis. So the crystals can either be free-floating in the canal, Okay, so this would be considered a canalithiasis. That means that they're just in the canal free floating. Then you could also have them where they get stuck and adhere to the cupula. This would be called a cupulothiasis. So they're both BPPV, but the crystals are just in a different spot in the semicircular canal. So once again, canalithiasis, they're free floating. Cupulothiasis, they are stuck to the cupula. So how do we tell whether it's a cupulothiasis or canalithiasis? So we look at how long the nystagmus lasts. Okay. So if nystagmus or symptoms last, well, yeah, the nystagmus or the symptoms last less than 60 seconds, we're going to consider it a canalithiasis. And that means, once again, that the otoconia are free floating in the semicircular canal. If the nystagmus or symptoms last longer than 60 seconds, we're going to categorize it as a cupulothiasis. So that means that the otoconia would be stuck on the cupula of the semicircular canal. Okay, I'm going to skip these slides for now because we're actually going to teach you how to do the Dix-Hallpike in lab. Okay, but the big thing that I want you to get out of it is that we're treating with the Dix-Hallpike. We're looking at anterior posterior canal involvement, and we're trying to figure out whether it's upbeating or downbeating nystagmus. Upbeating nystagmus is going to be posterior canal involvement. Downbeating is going to be anterior canal. The other thing we want to pay attention to is it greater than 60 seconds, it's a cupulothiasis. If it's less than 60 seconds, it's a canalithiasis. Now, what happens if you don't see nystagmus, but they're talking about the symptoms as if it's happening, like they're feeling like everything's spinning, but you're not seeing the eyes move? Remember that fixation can override nystagmus. So a lot of times people will override the nystagmus and you won't be able to see it when you're doing it unless you have the Frenzel glasses on or some of the infrared glasses to see it because they can't fixate as well. However, research has shown that if somebody is telling you, subjectively they're telling you all this stuff, objectively when you drop them down, they're complaining of the symptoms and they're lasting for less than 60 seconds and everything sounds like it's BPPV, you just can't see the nystagmus, you should go ahead and treat them. Okay? Because they have found that even with people just complaining of it without seeing the nystagmus, that 91% of the people improved and 87% of those basically just had subjective BPPV symptoms. Okay. So go ahead and treat. The reality is that they probably still have BPPV. You just can't see the nystagmus. But it is true BPPV. And if you go ahead and do the treatment, all the symptoms will subside for them. Okay. So let's say you still feel like it's BPPV, you dropped them back in the Dix-Hallpike onto the right and onto the left, and you didn't see any nystagmus. It didn't bring on any of their symptoms. Okay. So we do have, once again, we have 3 sets of canals. So we have the anterior, the posterior, and the horizontal. So we could also look at the horizontal canal because their BPPV could be located in the horizontal canal. We would do a roll test to look at the horizontal canal. Once again, we're going to teach you how to do the roll test in the lab. So I'm not going to go over the technique of the roll test right now, but we're going to go through all that in lab. But with the horizontal canal, the nystagmus is a little different. It's not upbeating or downbeating. It's now going to be a horizontal, but when we roll them onto their side. So because it's horizontal, it means that their eyes are either going to be down towards the ground or they're going to be up towards the ceiling. And so we call the nystagmus during the roll test either geotropic or ageotropic. And that simply just means geotropic means that it's beating down towards the earth. So it'd be beating down towards the floor. Ageotropic means that it's beating away from the earth, meaning it would be beating up towards the ceiling. Okay. So when we do a roll test checking for the horizontal canal, you're either going to see geotropic or ageotropic nystagmus. Remember, it's always named by the fast phase. So it's going to beat down towards the ground in a geotropic nystagmus, no matter which way you roll the person. So if you roll them onto their left ear, it's going to beat towards the ground. If you roll them onto the right ear, it's still going to beat towards the ground. Okay. If it's ageotropic, once again, it'll either beat away from the ground when they're laying on their left side, or if you roll them onto their right side, it'll also beat away from the earth and up towards the ceiling. Okay, so how do we interpret the roll test? Same thing, not any different. If it's less than 60 seconds, it's a canalithiasis. If it's greater than 60 seconds, it's going to be a cupulothiasis. So that doesn't change whether it's anterior, posterior, or horizontal. Greater than 60 seconds, cupulothiasis. Less than 60 seconds, canalithiasis. The tricky part with canalithiasis in the horizontal canal is that the way the canal is shaped, that there's a posterior portion of the horizontal canal and there's an anterior portion or anterior limb of the horizontal canal. And so depending on if it's in the posterior portion or the anterior portion, you're going to see a different type of nystagmus. We're going to talk about this a little bit more in lab to help you understand why that is the case, but just know that there's a little anterior limb and there's a posterior limb of the horizontal canal. If the crystals are in the posterior limb of the horizontal canal, you're going to see a geotropic nystagmus, and it's going to last less than 60 seconds because, once again, it's a canalithiasis, so it has to be less than 60 seconds. So no matter which way you roll them, you're going to see geotropic nystagmus for less than 60 seconds. Okay? And the side that ear is down when the symptoms are produced is going to be the ear that's involved. Now, if for some reason the crystals are in the anterior limb of the canal, and once again, we're going to talk about this more in lab and kind of go over the anatomy to help you understand this a little bit better. But for now, I just want you to know that if it's in the anterior limb of the canal, you're actually going to see ageotropic nystagmus. So the nystagmus is actually going to be away from the earth. So if it's in the anterior canal, it's going to be ageotropic, but it's still a canalithiasis, so it's going to last less than 60 seconds. Okay? Now, the strange thing that happens with this one is that if it's in the anterior canal, the involved side is whichever ear, when the ear is down. So if you're laying on your left side, if the symptoms are less when they lay on their left side, it is actually the left side that's involved. So in an anterior limb of the horizontal canal, the involved side is the side of the least amount of symptoms when the ear is down, whichever ear is down. In geotropic nystagmus, if it's in the posterior limb, then it's the side that has the greatest symptoms. So that can get very confusing when we start talking about the horizontal canal. We're going to review this all again in lab, but I want you to at least start to hear the concepts and start to get the ideas, okay? So anterior canal, ageotropic nystagmus, and the side with the least amount of symptoms is going to be the side that's involved. If it's in the posterior limb of the horizontal canal and it lasts less than 60 seconds, it's a canalithiasis, but it's going to be geotropic nystagmus, and it is going to be the ear that is down that has the greatest symptoms is going to be the side that is involved. Okay. Cupulothiasis, you're going to see ageotropic nystagmus with cupulothiasis, but the difference is that's going to last greater than 60 seconds. So that doesn't change. If it's more than 60 seconds, it's always going to be a cupulothiasis. And for the horizontal canal, you're going to see an ageotropic nystagmus attached with that greater than 60 seconds. Okay. So it will also follow the same concept that whichever ear is down, when the symptoms are produced, the least amount of symptoms is going to be that ear. So if you have less symptoms when you roll on to the left ear is actually the side that has the BPPV. Okay. So I know that can be a strange concept to try to grasp. We'll talk a little bit more in lab about the anatomy and why it is that way. Okay. And there you go. I'm going to leave them again right there for you a little bit just to remind you. And these are pictures of the roll test. We're not going to go over any of these at the moment. We're going to do all this in lab. And so I believe that is all I have for you for now.